eczema. An inflammatory condition. So inflammation is there. Inflammation, what is meant by inflammation is स्किन का इन्फ्लेमेशन होता है तो उसको डर्मेटाइटिस बोलते हैं. So, जिसका भी इन्फ्लेमेशन होता है वी एड आइटिस एट द एंड ऑफ द term. So skin inflammation is dermatitis. So all eczemas are dermatitis, but not all dermatitis are eczema. What does this sentence mean? ये सारे eczema तो dermatitis है, but सारे dermatitis eczema नहीं है. क्यों ऐसा? So eczema is an inflammatory condition of the skin that is characterized by, each and every word is important. Erythema means redness. Redness होगा, edema, papillovesicles, oozing and crusting in the acute stage, and lichenification in the chronic stage. So all these terms we'll discuss later on. And ecze in Greek means to boil over. Boil over means formation of some papillovesicular lesions. So all eczemas are dermatitis. All eczemas जो भी define किया है हमने, there is inflammation of the skin, but not in all inflammation of the skin we will call it as eczema. What are the examples जहाँ inflammation होता है but it's not an eczema? कुछ ये समझ में आया sentence? Derm means skin, itis means inflammation. So any skin inflammation is dermatitis. So skin inflammation can be produced by so many ways, methods, infections. Viral infection में भी inflammation हो जाता है, but then it's not dermatitis, it's not eczema. ठीक है ना? किसी भी bacterial infection में भी inflammation होता है skin का ना, but that bacteria is causing the inflammation. It's not called eczema. So this is very important. All eczemas are dermatitis. All eczemas have inflammation, but all inflammations cannot be called as eczema. So this is the itch scratch cycle. There is scratch which leads to itching, and itching will lead to scratch. So this phenomenon goes on. This is the cycle which propagates the presentation of eczema. The sensation of itch and subsequent scratching is the hallmark of most eczemas. So in all eczemas you will find itching is there, and there is sensation of itch, and it leads to scratching. Again, that scratching will increase the itching, and then this cycle goes on, and finally various presentations of eczema are there that we'll discuss in the topic today. So there are three types of eczemas: acute, subacute and chronic type of eczemas. So classification of eczema, it's mainly classified into two types. One is exogenous and other is endogenous. Exogenous means from outside. So any inflammation that is produced from etiologic agents from outside the body is exogenous eczema. That which is produced through the body, inside the body, and so many eczemas are there which are produced within the body. The body itself produces the eczema, that is endogenous type of eczemas. So exogenous are irritant contact dermatitis or irritant dermatitis. Irritant means any irritant applied to the skin may lead to inflammation and eczema. So irritants, there are so many irritants: detergents, soaps, acids, alkalis. Allergic contact dermatitis, allergy to something applied to the skin. There may be cosmetics, nickel, and so many things are there. Photodermatitis is produced through the sun. So sunlight will produce eczema over the skin, that is exogenous part. Dermatophytid is the fungal infections. This is also from outside. It doesn't occur within the body. It's from the outside that fungal infection inhibits the skin, and finally it will lead to dermatitic lesion. And hand eczemas, most of them are exogenous. These are produced by detergents, soaps, so many other things which our hand comes in contact with. Then endogenous eczemas are produced within the body. One is atopic dermatitis. So there is a tendency of eczema which is produced through the body. Pityriasis alba, seborrheic dermatitis, discoid eczema, hand eczema. So you'll see hand eczema is both in exogenous and endogenous. So it may be exogenous, it may be endogenous. Steatotic eczema, gravitational eczema, lichen simplex chronicus, and prurigo nodularis. So these are the examples of endogenous eczema. So we'll not go into details of each and everything. We'll see the definitions of these types of eczemas. So exogenous eczema, those related to clearly defined external trigger factor. So there is a trigger from the outside of the body. So these are external trigger factors. Inherited tendencies may play a part. So it's not that all our hands come in contact with sanitizer, detergents and soaps, but not all have eczema. We are also using the same soap, we are using the detergents, but not all will have hand eczema. So there is some inherited tendencies in few of the patients, which leads to this type of eczema in these patients. Then endogenous eczema, those mediated by internal factors, processes originating within the body. Some types of eczema is precipitated by both external and internal factors. Example is hand eczema. So clinical stages, the inflammatory changes of eczema involves through the three stages. One is acute eczematous inflammation, other is subacute, and third is chronic. It depends on the time. Acute means it comes initially and the presentation is also exaggerated. There may be papillovesicular lesions, too much of itching, oozing, and in the chronic form, the patient is having eczema since long time, he is scratching since many months, so presentation is bit different. So skin changes vary in different stages. So first we'll go through the acute eczematous inflammation. So classical clinical features in acute eczematous inflammation are intense itching. So this is acute stage. Acute means exaggerated part. So intense itching is there, intense erythema is there, and all this scratching will lead to edema, papillovesical formation, and finally oozing. So this is the classical presentation in cases of acute eczema. Examples are contact dermatitis, eruption, pompholyx. So contact dermatitis will go with this example. So some irritant application, sudden acid application is there to the hand, which will lead to intense erythema, itching, papillovesical formation. So this is a picture of acute eczematous inflammation where there is lot of erythema is there, oozing is there, vesiculation and erosion is there. So from this picture you can make out that it's acute stage where oozing is there, erythema is there. Then subacute form, erythema is there but lesser than the acute stage, and it start healing with crusting and scaling is there. In the initial stage there was erosion and oozing, papillovesicular formation. Here you'll find crusting and scaling, fissuring is there. Slight to moderate itching is there, stinging and burning sensation is there. So this example is osteototic eczema, atopic dermatitis and eczematized tinea. What is osteototic eczema? So each and every term is important. Through the term you'll make out the cause or the type of eczema. So it's caused by dryness. Dry eczema is osteototic eczema. Because of xerosis there is itching. Whenever we have dryness we start itching because of the dryness, and this whatever eczema is produced after that is osteototic eczema. Atopic dermatitis is from within, it's a type of endogenous eczema. Eczematized tinea is following infection with fungal infection. So this is a picture of subacute eczema where there is, you'll see that oozing is not there, erosion is not that much. Instead of erosion, the lesion has crust formation is there. It is a healing type of acute eczema where the erosion is healing with crusting. Erythema still is there because it's an active form. It's not a healing stage of eczema as such. It's a subacute type of eczema which is lesser intense than the acute eczema. So there is erythema is there. You can see on the periphery the erythema is there. This shows that the lesion is still active, but it is of a long duration. Acute means it's a short duration. It's a bit long duration. When crusting is there, erythema has subsided a bit, itching is less, but there is decrease in oozing. Then the third one is chronic eczematous inflammation. Chronic means it's very long, and the features are dryness of the skin becomes dry, excoriated, fissuring is there because of the dryness, which leads to fissuring, and finally the classical term that denotes chronic eczema is lichenification. Lichenification is, examples are lichen simplex chronicus, atopic dermatitis, pneumolar eczema. So these are the examples of chronic eczema. Lichenification is like a appearance of a bark of the tree. It has become thick, pigmented, and multiple lines are there like the bark of a tree. So this is an example of lichenification or chronic eczema, showing lichenification, hyperpigmentation. So initially in acute there was erythema, erosion was there. Here no redness is there as such. It has become pigmented, lichenified. Thickening of the skin is there and accentuation of the skin markings giving a tree bark appearance. So this becomes a chronic type of eczema. So eczema is one of the commonest term or presentation that we use in dermatology, and this is divided into acute phase, subacute phase, and the chronic phase of eczema. Now secondary dissemination or auto-eczematization. So once you have eczema at one part of the body, it may disseminate all over the body. This is what we call as disseminated dermatitis through the or secondary dissemination through auto-eczematization. So eczema has a characteristic tendency to spread far from its point of origin. So originally the eczema may start over the hands, but then slowly, if it is not untreated, it will spread to other parts of the body also. So this is the trigger, and then it spreads over the other parts of body, whether the contact is there or not. So contact may be only over the hands, but the presentation may be slowly, it may spread to other parts of the body. So this is what we call as secondary dissemination, or finally what we call as disseminated dermatitis, known as secondary dissemination or auto-eczematization. So body itself is propagating the eczema to other parts of the body. Once the process starts at one place, it may spread to other parts of the body. Like infection, there is bacterial infection at one place. Once you touch that place and touch your hand to other parts of the body, the bacteria is transferred to the other parts, and there may be infection on the other parts of the body. But in eczema, it spreads through the internal route. Secondary eczema lesions like small edematous papules, plaques, grouped papulovesical lesion. It subsides if the primary lesion settles, but it often recurs if the primary lesion relapses. So the treatment management depends on the treatment of the primary lesion. If that is treated slowly, the other parts will also resolve. So this is important to know the cause of eczema. There are so many types of eczema. So once you should know exactly what is the cause, and it should be treated properly. So eczema, there are so many types of eczema. Whenever the patient comes with itching and scratching, we say he is having eczema. But what type of eczema is having? So classification is very important. The prognosis depends on the classification. Some will not heal, some will take a long time, some may heal quickly. So eczema, the background may be same, but the etiopathogenesis should be treated properly so that we can treat the eczema. So secondary dissemination, mechanisms of secondary dissemination is contact with an external allergen, injection of an allergen. Sometimes suppose a case of contact dermatitis with nickel is there. Nickel is one of the common metal that causes contact dermatitis. So you'll see people having eczema over the hand where they are wearing the watches. The watch, if nickel is there, it will produce eczematous lesion on that part. And then there are certain food items which contains nickel. If such food is ingested, once the patient is sensitized to nickel, the lesions may be there all over the body. So injection of the allergen, conditioned hyperirritability and bacterial hypersensitivity. So these are the other common causes which leads to dissemination of the eczema. So first we'll go through the exogenous eczemas that are through outside. One the most common cause is contact, what we call as contact dermatitis. So contact dermatitis is again divided into two: irritant contact dermatitis and allergic contact dermatitis. So non-immunological inflammatory reaction of the skin due to an external agent. So it is non-immunological, is irritant contact dermatitis. It will immediately cause reaction and eczema. Suppose the application of acid. Once you apply acid, there will be vesiculation, erythema, and this is what we call as irritant contact dermatitis. Contact to the acid will lead to eczema, what we call as irritant contact. There is no immunology involved in it. It is the direct effect of acid over the skin. So irritant CD is non-immunological. It is because of the uh, acute effect of whatever application that is done over the skin. So varied morphology is there according to the application type. So clinical types are symptomatic subjective irritant response. Chemical burns comes under acid applications in other irritant application. Acute irritant contact dermatitis, and there may be chronic irritant contact dermatitis also. So acute irritant is through the alkalis and acids, whereas chronic contact irritant contact dermatitis examples are the detergents, soaps, water even. Okay, so those who are working in water or cleaning the utensils, they will not get irritant CD on the same day. If they are doing the same job since 1 or 2 months, finally the skin will become rough and excoriated, fissured. This is what we call is chronic irritant contact dermatitis. So these are the examples of irritant dermatitis. Acute irritant dermatitis due to direct Dettol application. So sometimes we see that any injury or wound is there, we apply the Dettol directly over it, and if it is applied for a long time, it may itself will cause irritation of the skin, showing erythema, vesiculation, oozing, and erosion. So this is not because of the infection. This is because of the Dettol application in high concentration over the skin for a very long time. So this will lead to a type of eczema, what we call is acute dermatitis, and the type is irritant contact dermatitis. Other is irritant dermatitis due to balm application. You will see when headache is there, people they apply balm over the forehead. So if this is applied for a long time or left over the forehead, it will lead to dermatitis over that region. This is again an example of irritant dermatitis over the forehead. And third one is irritant dermatitis due to selenium sulfide application. So this is done in, what is selenium sulfide? Any example where it is used? So this is what we get in Selsun shampoo was there. This was used to treat tinea versicolor and other lesions. So if this is applied over the skin, even this is a shampoo, and if it is not washed within few minutes, it may lead to irritant contact dermatitis. If any irritant is applied over the skin and kept for a long time, it will lead to dermatitis, what we call as irritant contact dermatitis. So these are the examples: application of Dettol, balm, or any medication which has to be washed. If it is not washed, it may lead to contact dermatitis. Then comes the chronic irritant contact dermatitis. These are the common irritants which causes chronic irritant contact dermatitis. These are water and wet work, sweating under occlusion, household agents like detergents, soaps, shampoos, disinfectants, industrial cleansing agents like solvents, abrasives, alkalis, cement and acids may cause. If cement workers, they are working with cement for a long time, finally they get this type of irritant contact dermatitis. And there are certain ingredients in cement which may also cause allergic contact dermatitis. Cutting oil, organic solvent, oxidizing agents. So it's a long list which causes irritant contact dermatitis. And then chronic irritant dermatitis, common irritants are reducing agents like phenol, certain plants, pesticides, desiccant, powders, soil, miscellaneous chemicals. So person at risk of chronic irritant contact dermatitis are the mothers due to repeated washing of child's diaper or even washing clothes regularly. Cleaning utensils in females usually leads to irritant type of contact dermatitis over the hands. Housewives, persons with atopic diathesis. So this is much more common in having patients having atopic diathesis. There are so many females or males cleansing utensils, but not all of them will get this. But those who are atopics are much more prone to get contact dermatitis, both irritant and allergic type of contact dermatitis. Persons in occupation of hairdressing, medical, dental, veterinary, food preparations, catering, fishing, printing. So all these occupations involve chemicals and other usages which may lead to irritant and allergic contact dermatitis, both of them. Coming to allergic contact dermatitis, this is immunology is involved in contact dermatitis, allergic contact dermatitis. This is a delayed type hypersensitivity reaction that occurs upon contact of skin with an allergen. So it is not immediate. Initially there is application and patient's skin is sensitized, and finally if that application is repeated, it may lead to eczema. So this is the difference between irritant and allergic contact dermatitis. Irritant will be in the first application itself, and allergic will not be there in the first application. The body is sensitized to the allergen, and if that application is repeated, it may lead to allergic contact dermatitis. So inflammatory reaction following absorption of antigen applied to the skin with prior sensitization develops within 15 to 48 hours of antigen exposure and persists for 3 to 4. So this is not immediate. It takes around 12 hours to 2 days to develop the eczema. This is what we use in patch testing. So if you want to know which allergen is causing the contact dermatitis, we usually apply patches over the back. That is to be kept for at least 2 days, and then we know what allergen is causing eczema in that person. So this is the immunological mechanism. One is induction. Once you apply the allergen for the first time, there is induction. The allergen is applied to the skin and Langerhans cells via the afferent lymphatics. They sensitize the T cells, and there is proliferation of these sensitized T cells, and this leads to formation of memory T cells. So these T cells memorize which allergen has been there, and once the application is again that allergen is applied, the memory T cells will lead to release of cytokines and finally formation of the eczematous part where there is swelling, vesiculation, erythema, oozing. So what are the different parts of inflammation? What is inflammation? ये तो आपके फर्स्ट ईयर में हो गए सारे. इन्फ्लेमेशन में क्या क्या होता है? 5 होती हैं कि 6 चीजें होती हैं कितनी? Redness is there. What we call is rubor and tumor, dollar. क्या ये सब चीजें क्या क्या हैं बताओ आपने? So inflammation, what we were discussing is dermatitis is inflammation, where there is erythema, then swelling, pain, और क्या होता है? टेम्परेचर, आपको हीट फील होगी, आप टच करोगे तो इट इज लिटिल वार्म. एंड फिफ्थ इज लॉस ऑफ फंक्शन. कुछ ऐसा क्या है पर्ल? फिफ्थ इज लॉस ऑफ फंक्शन. सो वंस ऑल दिस इज देयर, दैट पार्ट विल नॉट वर्क properly. So this is what we call it loss of function. So this is the inflammation which takes place because of the cytokines, and finally there is inflammation is there, that is swelling is there, little warmth is there, vesiculation is there. So allergic contact dermatitis, clinical features in acute inflammation, well demarcated patches of erythema, edema, vesicles and bullae. So these all are the parts of eczema that we see. So in this is in contact dermatitis, we'll get erythema, edema, vesiculation, bullae. Similarly, we'll get same thing in irritant contact dermatitis. Then it may be linear, erosive and crusted lesions may be there. What is the cause of linear lesion in allergic contact dermatitis? Scratches, linear application हो सकता है. If the contact allergen is applied in a linear method, it will lead to linear contact dermatitis. So this is depends on the application. So through the eczematous part, you will be able to know कि वहाँ पे क्या contact हुआ है. हाथ पे है तो आपका हाथ का पता लगेगा, सिर पे है तो आप ये बाम जो लगाया फोरहेड पे, उससे पता लगेगा. आप पेशेंट से पूछोगे कुछ, आप बाम तो नहीं लगाते हो, पेशेंट थोड़ी बताएगा ना, उसे पता होगा कि बाम की वजह से मुझे हो रहा है. कुछ लोगों को पता लग जाएगा, बार बार होगा. अदरवाइज फोरहेड पे कह रहा है मुझे इचिंग हो रही है, इन्फ्लेमेशन हो रहा है, तो आप पूछोगे आप लगाते क्या हो यहाँ पे ना. सो थ्रू दैट part you will be able to diagnose what all things are applied over that region, and you can able to diagnose that this is because of the balm. आप उसको बंद करें तो वो ठीक हो जाएगा. So this is the easiest way to treat, कि जिससे पता लग जाए कि इससे हो रहा है, उसको बंद करोगे तो आप वापस रिकर नहीं होगा, ठीक हो जाए. So there are so many types of applications which lead to allergic contact dermatitis. One of them is बिंदी. बिंदी लगाते हैं, वहाँ भी कई बार किसी को एक्जिमा हो जाता है. That is what we call as Bindi Dermatitis. So that is because of the allergen, that is the sticky material that is put in the bindi, and it is to be applied on that region. It may lead to eczema, it may even lead to leukoderma or whiteness of the skin. Similarly, lipsticks also they cause inflammation and eczematous reaction over the lips. So once you get this, you know what is applied over that region. If that is stopped, it can be treated easily. Then chronic inflammation leads to lichenification, scaling, and fissuring that we already read. The two types of eczema, that is acute and subacute and chronic. Then all these three can be present in exogenous eczema, endogenous eczema, and contact dermatitis, whether it is irritant or allergic contact dermatitis. So clinical features depend on the location that we already read. कि location पे कुछ पता लगेगा यहाँ पे eczema हो रही थी, वहाँ आप क्या पहनते हो. अगर वॉच की जगह पे है तो we know that this is because of the watch. बेल्ट की जगह पे, बेल्ट के जो बकल्स होते हैं, you'll find eczematous lesion over the infra umbilical region. So that अगर आप देखो पेशेंट ने पहन रखा है इस तरह पैंट पे बेल्ट, और बेल्ट का वो हुक या बकल उसके स्किन पे लग रहा है, that may cause reaction if it is having nickel. So through the location you will be able to diagnose the cause, and if that cause is removed, it can be treated. Duration of contact with the allergen. Intensity of the inflammation depends on the degree of sensitivity and concentration of the antigen. So these are the common allergens and the causes of allergic contact dermatitis. So in artificial jewelry you will find nickel is there and cobalt is there. Chromium is present in cement and paints. Then potassium dichromate is present in leather and detergents. Epoxy resins, phenols are present in plastics. So plastics, all this may cause allergic contact dermatitis. The plants, the most common is Parthenium. So Parthenium dermatitis is one of the most common type of allergic contact dermatitis in Rajasthan. So this is because of the plant Parthenium, having Parthenium. This is present in Congress grass. There is a type of grass which has this Parthenium, and if that is present around a person, it may lead to sort of allergic contact dermatitis over the body, especially over the exposed part of the body. Then cosmetics and medicaments. Hair dye is one of the most common ingredient causing allergic contact dermatitis. And the agent is PPD. What is the full form of PPD? PPD is a chemical which is present in dyes which causes allergic CD. कई बार देखते हो ना dye को, we say कि before applying dye just do a patch test over the retroauricular region. If there is eczema, then don't use the dye. So sometimes we see many patients, they come on the first application of dye or the second application of dye, there is eczema all over the scalp and the forehead. क्या है PPD पल? So this is paraphenyldiamine. This is the chemical which is present in dye, which is responsible for allergic CD to dyes. आजकल मेहंदी बोलते हैं, आप PPD से प्रॉब्लम हो रहा है डाई से, तो मेहंदी लगा लो. बट देन मेहंदी जो काली मेहंदी होती है, दैट आल्सो कंटेन्स PPD. मेहंदी जो ओरिजिनल होती है ब्राउनिश, दैट इज द ओनली वन विच इज नॉट हैविंग PPD. अब लोग कहते हैं कि डाई से हो गया है तो काली मेहंदी लगा. So काली मेहंदी इज आल्सो बिकॉज ऑफ that color is because of the PPD. Again, it will also cause the contact dermatitis. Then certain medicaments also may lead to contact dermatitis, like neomycin and gentamicin. So these are the examples of allergic contact dermatitis. So allergic contact dermatitis due to spectacles. Why there is allergic CD to spectacles? क्या हो गया उससे ना, चश्मे में क्या ऐसा है जो, हाँ, प्लास्टिक में कॉज. प्लास्टिक इज वन ऑफ द लीस्ट एलर्जिक पार्ट. इसमें आप देख रहे हो ना, मेटल टच हो रहा है स्किन के ऊपर. तो मेटल इज मोस्ट ऑफ द कॉमन विच कंटेन्स निकल. निकल इज द मोस्ट कॉमन एलर्जन विच कॉजेज कॉन्टैक्ट डर्मेटाइटिस. सो इसमें इसलिए तो उसके ऊपर वो प्लास्टिक लगाते हैं, और भी प्लास्टिक बचाने के लिए लगाते हैं. प्लास्टिक अगर लगा हुआ होता है तो एलर्जिक सीडी कम होता है. कईयों का प्लास्टिक नहीं होता है, या प्लास्टिक उतर जाता है, या थोड़ी सी जगह पे होता है. तो इफ मेटल इज इन कांटेक्ट विद द स्किन फॉर अ वेरी लॉन्ग टाइम, इट लीड्स टू सेंसिटाइजेशन एंड फाइनली एलर्जिक कॉन्टैक्ट डर्मेटाइटिस. सेकंड इज ड्यू टू मेटेलिक फास्टनर्स. फास्टनर्स किस में होंगे मेटेलिक फास्टनर्स? जीन्स का होता है बटन, वो अंदर से भी मेटेलिक होता है, बाहर से भी मेटेलिक होता है. If that is in direct contact with the skin, it may lead to sensitization and finally allergic CD, and the common cause again is nickel. So most of the metals contain nickel and they may lead to allergic contact dermatitis in few of the predisposed people. Then again Bindi dermatitis is again it's causing eczema at the Bindi region. So this is because of the eosin which is present in the uh, sticking whatever sticking plast is applied over the Bindi, it causes Bindi dermatitis. And the fourth one, the second one is the Semen Dermatitis. So cement itself may lead to contact dermatitis because of the allergen present in cement. So mainly cement workers, the hands and feet are exposed because they are working in the cement. If allergy patient presents with dermatitis over the hands and feet, ideally we have to find out what all allergens are in contact with that. If a cement worker, cement is the most common allergen again. So allergic contact dermatitis, the most important investigation that we do is the patch testing. We apply a patch, we have a series, Indian series is there, cosmetic series is there, footwear series is there, plant series is there. So if we find that patient is having allergic to certain plants, we have a plant series which we apply over the back, and then that is to be in place for 2 days. We remove after 2 days, and wherever there is eczema, we are able to find out which plant or which allergen is responsible for that. And we have a list of suggestions to the patient that if he is allergic to nickel, he has to avoid so many things. So that contains watches and belts and so many things. And there is a test where we will be able to find if the nickel is present in that metal or not. तो उससे भी आप कर सकते हो कि वो टेस्ट फटाफट किसी भी मेटल पे कर लिया, अगर वो आता है पॉजिटिव दैट मीन्स निकल इज देयर, इफ इट इज नेगेटिव दैट मीन्स निकल इज नॉट देयर, यू कैन वियर दैट metal or use that metal for it. It is the miniature reproduction of eczema by application of allergen on the intact skin of patient of allergic CD. It should be undertaken for patients in whom the inflammation persists even after avoidance of the offending agent. So this is not the first instance we apply patch testing. We try to treat the patient. Most of the time there is no recurrence. If recurrence is there and it becomes chronic, then we try to find out the cause, and if we find the cause, then only we'll be able to treat the patient. Otherwise it will recur after stoppage of the treatment. So these are the patches that we apply over the back. So it contains this aluminum chambers are there where the allergen is applied, and that this is applied to the back, upper back, and this is left for 2 days. So we advise patient not to go for exercise, not to go outside in the sun because of sweating it will come out, not to take bath for 2 days, and then on removal of the patches in the second picture you can see there are few allergens which have become positive. So this is how we will be able to know which all allergen the patient is allergic to or sensitized to. So this is the reading that is done. Not all positives are positive. There are certain positives, even irritation may cause positive reaction, then it's a part of irritant CD, not a contact dermatitis. So we will not go into details of this. This you will see when you come to the OPD. So other part is photodermatitis, that is from the sun. So eczematous response of the skin to sunlight is photodermatitis. So this is again from external factor, so it's an exogenous type of eczema, typically on the light exposed area of the skin. So easily you will be able to find that this is this is a case of photodermatitis because it will be especially on the photo exposed part. आपका जो body का covered area that is spared, and even on the face there are certain like allergic contact dermatitis from Parthenium. It is also on the exposed part because Parthenium plant will also affect the exposed part only. Then photodermatitis will also affect the exposed part. So how to differentiate between these two types of eczema? जो भी external allergen होगा, one is ABCD, what we call is ABCD, airborne contact dermatitis, through the air. That Parthenium plant, it's not necessary to hold the plant to get in allergy. It is in the air. That Parthenium comes in the air, and wherever it strikes a sensitized person, he'll get eczema over that area. So that is also on the exposed part only because clothing के ऊपर जाएगा तो असर होगा नहीं. So what is the difference between photocontact dermatitis and airborne contact dermatitis? So certain regions where the skin is saved from the sun exposure. There are two important places. आप बाहर ऐसे खड़े होते हो तो एक तो चिन के नीचे है, यहाँ पे सन नहीं लगता. If this is spared, that means the case of photodermatitis. क्योंकि हवा तो सब जगह लगती है, बट सनलाइट इस जगह पे नहीं लगेगी. अपर आईलिड पे सनलाइट नहीं लगती है, बिकॉज हम आंखें खोल के चलते हैं, बंद करके तो कोई बाहर नहीं चलेगा. तो अपर eyelid is saved from sun exposure. And third is retroauricular region. इसकी वजह से इसकी छाया में पीछे कभी photodermatitis होता नहीं है. So these are the three important places where if these are spared, that means patient is suffering from photodermatitis, not allergic contact dermatitis or airborne contact dermatitis. So types of reaction to sunlight are phototoxic, photoallergic, eczematous. Will not go into details of these. So what is the difference between phototoxic and photoallergic reactions? It's a common is phototoxic, non-immunological. It's a type of irritant CD. It's similar to irritant and allergic contact dermatitis. Sunburn is a case of phototoxic dermatitis. It will be like a sunburn. So once you are exposed to the sun, directly you will get redness or tanning, whatever it is. That is phototoxic. Immediately you will get, as in cases of irritant contact dermatitis. That what you get in the second instance is allergic type of reaction. This is photodermatitis or eczematous type of photoallergic contact dermatitis. Clinically diagnosed photopatch testing is required. Phototoxic reactions inducing agents are perfumes, dyes, psoralen stars. Systemic also. Certain systemic agents may cause photosensitivity. Tetracyclines, if given and patient goes out in the sun, then chances of photodermatitis are much more. So certain drugs and local applications may exaggerate the response of sunlight over the body. So usually we ask patients to avoid using Dettol soap or Lifebuoy soaps. So these soaps are red and they contain certain photosensitizers. So you get much more reactions, photosensitivity in those patients who are using Dettol and Lifebuoy soaps. So perfumes, again, if you apply perfume over the face and go out in the sun, the chances of photodermatitis are much more. Dyes, psoralen stars, lime application over the skin and photo exposure will lead to burn over that area. So this is an example of phototoxic dermatitis. So psoralen induced phototoxic reaction showing erythema and bulla formation. So even bullous lesions may be there if an allergen is toxic application is there and photo exposure is there. Photoallergic reactions, these are the inducing agent which leads to photoallergic reactions. Again, perfumes, certain sunscreens which contain PABA may cause allergic reactions. So usually, ideally we support the application of physical type of sunscreens. So physical sunscreen, what is the difference between physical and chemical sunscreens? सनस्क्रीन आप लगाते होंगे ना सब लोग. No, that is not physical sunscreen. Applications. So physical. Now there is tendency to apply sunscreens without any exposure to the sun, especially in India. हमारा कोई सन एक्सपोजर होता नहीं है, बट मोस्टली इतना प्रोपोगेट किया जाता है कि सनस्क्रीन लगा के घूमो, सुबह से रात तक लगाना है इसको. ना लगा भी रहे होंगे आप लोग, काफ़ी लोग ना. इट इज़ वन ऑफ द यूजलेस एप्लीकेशन दैट इज बीइंग डन इफ़ यू आर नॉट एक्सपोज्ड. अगर बाहर जाते हो 3-4 घंटे के लिए, देन इट इज़ गुड. अदरवाइज सुबह से आप कुछ लगा के बैठे हो, दैट में फाइनली लीड टू allergic sort of reaction, allergic contact dermatitis. So sunscreens containing PABA may cause allergy in few of the people using this. So physical sunscreen is the best if you are able to apply that. Physically, it will block physically. It is not, the sun rays are not absorbed by the sunscreen. It just reflects the sunscreen. But then the problem is that it is little visible. थोड़ा सा आपको लगता है कि लगाएं भी और दिखे भी नहीं. So people prefer such types of sunscreen. और जो फिजिकल होते हैं थोड़े से वो वाइटिश से होते हैं, जो आप प्लेयर्स को देखते होंगे, क्रिकेट प्लेयर्स यहाँ वाइट लगा के चलते हैं. दैट इज़ अ टाइप ऑफ फिजिकल सनस्क्रीन, बट देन दैट इज़ टू मच वाइट, नोबडी विल अप्लाई दैट. बट अब जो आते हैं similar to foundation, हल्का सा लगेगा कि कुछ pinkish है, whitish है. These are the safest sunscreen that can be applied. And chemical sunscreens are the sunscreens which absorb the sunlight. It will absorb and it will not allow to enter into the skin. But then it itself may cause allergic contact dermatitis. Halogenated compounds, and Parthenium again is an agent which causes contact dermatitis, but it may also aggravate the eczema with the sun application. So sun may sensitize the allergic contact dermatitis due to Parthenium. Then certain systemic drugs may aggravate the photoallergic reactions like NSAIDs and thiazides and phenothiazines. Photoallergic reaction, Parthenium induced photoallergic reaction. Will not go into detail. This is the plant which is very common in Rajasthan and which causes a sort of photocontact dermatitis as well as photoallergic dermatitis. And this is the features over the face on the exposed area. But in such a cases where there is combination of both allergic and photo component, the whole of the face and other areas may be involved. Polymorphous bright eruption. So this is a reaction which takes place because of the sun, and there are many types of skin lesions. Polymorphous means various types of skin lesion. There may be papule, there may be plaque. So this is a type of polymorphous light reaction over the neck, over the face. This is photo-induced. Dermatophytid eczematous reaction that occurs as allergic response to a dermatophyte infection or the fungal infection elsewhere over the body. So this is the dermatophytid. What we call is Eid eruption. So Eid eruption is a vesiculation mainly over the sides of the fingers, but the fungal infection is somewhere else. It's not the fungal infection directly. Fungal infection is the sensitizer. If you find such a presentation, we have to ask the patient if there is any fungal infection in the body. Usually find Tinea cruris or corporis, whatever. So that is the cause of this type of reaction. So if that is treated, this will also subside. Hand eczema, again, it may both be endogenous and exogenous. So I think enough for today.